So we are coming to the skull because we are going from most superficial downwards. The skull is an entity in itself. It is a jigsaw puzzle of irregular bones and very specific puzzle edges that combine to form a masterpiece. It is a helmet for the brain and a scaffold for the face. I have taken this quote from Professor Aaron Cohen's Neurosurgical Atlas. It was his own quote and I really liked it and I'm really pleased to share it with you. The skull is divided into neurocranium, which is the brain case, and the vitrocranium, that is the facial skeleton. I need to tell you about the diploid, which is the journal's term to use, to describe the spongy or cancelled region of the intervening bone. You can see over here, I have added this picture. This is that lies between the hard cortical shell and the brittle inner shell. You can see this is the diploid, and it should be noted that only one-third of children under the age of 3 years will have a diploid space detected by CT scan, while the diploid space is visible in the interior parietal region of the scalp in up to 82% of children aged 3 to 5 years. The thickness of the calvarium and the breadth of diploid space in children, um, you can see over here. I can see, okay, no, no, I think it's evident on the Zoom. Yes, okay, it's not visible. It's visible on the thickness of the calvarium and the breadth of the diplex within children can aid surgical planning for split thickness calvarial bone grafting when needed in calvarial reconstruction. So this point is very important for you to remember. Okay, I'm just adding a few things about the skull. This is the ping pong skull fracture. You can see over here, it's like a little indentation over here. If you put your finger on the ping pong, you can see the similar indentation. So ping pong skull fracture or pond skull fracture refers to a depressed skull fracture of the infant skull that is caused by inner buckling of the calvarium. It is seen in newborns because of the soft and resilient nature of their bones. The fracture is called a ping pong fracture because it resembles a ping pong ball that has been indented in bursts with the finger. You can see over here. So it is like a little indentation. And the Lucan chandle skull. Yes, you need to know about this too. I've taken this picture from Wikipedia. Lucan chandle is a compound German word derived from Luke, meaning gap, and shadow, meaning skull. So Lucan chandle skull, also known as lacunar skull or craniolacunae, is a dysplasia of the membranous skull vault and is associated with cavity malformations seen in up to 80% of such cases. The inner table is more affected than the outer table, with the regions of apparent thinning corresponding to unossified fibrous bone of the skull vault. It particularly severe with the individual lacunae coalescing into larger defects. The term craniophenistry is used. In associations you need to know about this are the Carrari 2 malformations, encephalocele, and myelomeningocele. So you can see over here, and you need to remember this, and it is of serious clinical interest. And the defect is not one of the pressure from within in contrast to the copper beaten skull appearance of hydrocephalus or normal convolutional markings, but it is rather of abnormal collagen development and ossification over here. So the skull wall ossification process is in the membranous ossification. So it is present at birth and disappears by 5 months of age. And looking channel skull is characterized by groups of round, oval, or finger-shaped plates on the inner surface of the wall membranous part separated by ridges of bone. They lie in the thickest part of the frontal, parietal, and the upper occipital bone. And this is the copper beaten skull. Again, this picture is from Radiopedia. I'm really thankful to everyone who has, added so many things for us to know. So it's we really owe them a big thanks. This is also referred to as the beaten silver skull because it resembles the beaten silver pots you might have seen in the movies and elsewhere, and even some of us do have these. They are quite trendy in trendy part of cutlery of crockery. So you might have known about that. So you have a good idea. So, these refers to the prominence of convolutional markings, the garden impression in the inner table of the skull, seen throughout the skull vault. The appearance of copper beaten skull is associated with raised intracranial pressure in children. Convolution markings may be normal, but they're usually confined to the posterior part of the skull's inner table. So, associations: craniosynostosis, obstructive hydrocephalus, hypophosphatasia, and intracranial masses. This is again the diploid I want to show you. So between the outer and the inner table, you can see this is the diploid. And now we are coming to the skull. So this is the anterior view. You can see the forehead, the full area is the frontal bone. And this is little, this is the zygomatic process of the frontal bone. You can see this is the supraorbital knot with the supraorbital nerve. And this little elevation is the glabella. It lies above the nasion, which is the bridge, also known as the bridge of the nose. And it is a midline bony depression between, you can see over here, I have added a special picture. It is a midline bony depression between the, you can see between both of your eyes, where the frontal and the two nasal bones meet below the glabella. These are the two nasal bones. You can see they have combined in the middle, and this is the nasion and the nasofrontal suture over here that you can see between, this is the superior orbital fissure that is located between the lesser and the greater wing of the sphenoidal bone. And going middle, you can see over here, this is the optic canal for the optic nerve. This is something that you should know about. And coming over here, you can see this thin bone. This is the perpendicular plate of the ethmoidal bone. You can see over here, this is going perpendicularly. This is the, you should know about it. This is the middle nasal concha that you can see. And this is coming out over here is the interior nasal spine. You can see this. And infraorbital foramen over here, these small little holes you can see over here. And this is the coming on. This is the mandible. This is the condylar and the coordinate processes. And so you can see from here is the mastoid process of the temporal bone. Obviously, you can see over here. This is the maxilla, and this is the frontal process of the maxilla. You can see it's going upwards. And I think that we have another pictures for you to see clearly. Now we have going to tell you about the orbit. So imagine it is a pyramidal structure with the apex pointing posteriorly and the base is situated anteriorly, and it is formed by 7 bones. So again, if we are going into, there's a superior root. So this is the roof of the orbit, the superior wall you can see, which is formed by the frontal bone and the lesser wing of sphenoid. I think you can appreciate it. This is the frontal bone and this is the lesser wing of sphenoid that is forming the roof. And the frontal bone separates the orbit from the anterior cranial fossa. And now this is the floor of the orbit, and it is formed by maxilla, the palatine bone, and the zygomatic bones. You can see over here in this figure, this is the maxillary bone, this is the zygomatic bone over here, and this is, you can see this little bone which is where you have seen written A, and this is the palatine bone, the orbital process of the palatine bone that you can see over here. This is the lateral wall of the orbit, which is formed by the zygomatic bone and the greater wing of sphenoid. You can see over here, this is the greater wing of sphenoid, and this is the zygomatic bone. And this is the medial wall, which is formed by the ethmoid, maxilla, lacrimal, and the sphenoidal bones. You can see it quite clearly over here. I think it's quite good enough for you to know. This is the lacrimal bone coming down. This is the ethmoid bone over here. And this is a maxillary bone. You can see over here, you can follow it quite well. And obviously the sphenoidal bone, you can see from here quite nicely. So I think it's quite a good picture for you to remember. So this is what you can see. This is the structure of the orbit. Now we are coming into the apex of orbit, because as I have mentioned before, you have to think of orbit like a pyramid. So the base is what you can see is the eye, which is covered with the eyelids and open to the surface, and the base is basic, and the apex is deep down posteriorly. So the orbital apex is anatomically the posterior part of the orbit that is positioned at the craniofacial junction located where the 4 orbital walls converge together. The orbital apex incorporates the optic canal and the superior orbital fissure. You can see over here, this is the superior orbital fissure along with its contents that you have that you can appreciate. Okay, so I have already mentioned that there are the contents include, this is the lateral and the frontal branches you can see of the V1, the ophthalmic division of the trigeminal nerve. Okay, so coming down here, is the fourth cranial nerve. You can see the trochlear nerve over here. This is the superior and the inferior division of the oculomotor nerve. That is the third cranial nerve. You can also appreciate the sixth cranial nerve over here. This is the abducens nerve. Superior ophthalmic vein is also there. And also, I want to show you about this annulus of zinc. Can you see this is a black and white type of a ring? You can see over here, and the annulus of zinc is basically a dense fibrous ring of connective tissue located at the apex of the orbit. That is the origin of the four of the six extraocular muscle, the superior rectus, the SR. You might be able to see the SR, the superior rectus muscle, IR, the inferior rectus muscle, the lateral rectus muscle that you can see depicted with LR, and the medial rectus muscle, MR. These are the red markings that show you the extraocular muscles, which are originated from the annulus of Sim, and this is the optic nerve. You can see over here. The superior orbital fissure is tackled by the following structures. Like I have mentioned before, you should also go through this list. And the superior orbital fissure is divided into three parts from lateral to medial. The lateral part transfers the superior ophthalmic vein, the lacrimal nerve, the frontal nerve, the trochlear nerve, recurrent meningeal branch of lacrimal artery. And the middle part consists of superior and inferior division of the oculomotor nerve. And the medial part, the inferior ophthalmic vein, and sympathetic nerves arising from the plexus that accompanies the internal carotid artery. And there's also the superior orbital fissure syndrome that you need to know about. And you actually need to know about the difference between superior orbital fissure syndrome and the orbital apex syndrome, because there's a difference over here. If you say it is the orbital apex syndrome, then you need to know that the orbital apex syndrome is differentiated from the superior orbital fissure syndrome by the involvement of the optic nerve, which is not present in the superior orbital fissure syndrome. So in superior orbital fissure syndrome, or the Rochon-Dovinier syndrome, as we say, enclosed lesions that are found directly anterior towards the orbital apex, together with the structures leaving the annulus of Sin, and frequently the ones located external towards the annulus. And it was multiple cranial nerve palsies that may be seen, including without any optic nerve pathology, which is very important for you to distinguish it from the orbital apex syndrome. So the nerves that are involved are the oculomotor nerve, trochlear nerve, opticus nerve, ophthalmic branch of trigeminal nerve, and whenever the cranial nerves that traverse the superior orbital fissure get involved, many alternate results may happen, like diplopia, paralysis of the extraocular muscles, ectophthalmos, ptosis, blindness or loss of vision in the orbital apex syndrome. So now coming towards the orbital apex syndrome, it involves the cranial neuropathy in association with optic nerve dysfunction. This is important. So there's a constellation of symptoms and signs which result from involvement of various structures in the region of the orbital apex. These structures include the four rectus muscle, taking their origin from the tendinous annulus of Zen. Their optic nerve and the ophthalmic artery through the optic canal, the superior and inferior branches of the oculomotor nerve, the abducens nerve, and the nasociliary branch pass through the annulus of and through the middle portion of superior orbital fissure. The most common clinical feature of a disease process in the orbital apex are vision loss and painful and limited eye movements. So you will be having a patient with proptosis and present an absence of corneal sensation and corneal cracks that indicate the involvement of the fifth cranial nerve, pupillary pneumatics, a relative afferent defects, and isochoria and optic disadem or optic atrophy. Now coming towards the lateral surface of the skull, you can see over here, this is the most common thing that you remember all the time, because we are always dealing with this very much. This is the frontal bone, and these are the two parietal bones, and this is the occipital bone. You can see that the coronal suture lies between the frontal bone and the two parietal bones. They are joined together, rather. The frontal bone joins the two parietal bones at the coronal suture. You can see over here, and the point where the two parietal bones are joined together through the sagittal suture, and where the sagittal suture comes in contact with the coronal suture, that point is referred to as the bregma. And similarly, two parietal bones are joined to the occipital bone through this lambdoid suture, and again, the point where the sagittal suture comes in contact with the lambdoid suture is known as the lambda. And here you can see this is the squamous part of the temporal bone. You can see this is the squamous suture lying over here, and coming down here, it is again, you can see this little bone. This is the greater wing of the sphenoidal bone, and this is, can you appreciate this H-shaped point? This is the pterion. We will have some other slide for this pterion because it is an important structure for you to know and remember about. So again, where you can see the frontal bone, the parietal bone, the temporal, and the sphenoidal bone come together. This point is the pterion. You might have known it well because of the pterional approach that is centered around the pterion, and it is also the thinnest part of the skull, and any blow here can lead to the formation of extradural hematoma, since the pterion overlies the anterior division of the middle meningeal artery. Coming down here, it is the external acoustic opening, and this is the mastoid process, and this is the external occipital protubers, the inion, as you all know about it. You can see this is the zygomatic bone lying over here. Okay, you already know about it. This is the zygomatic arch, and these points are extremely important for us as neurosurgeons. So I think this is quite good enough, and we are just going just to have tried to our best to give you the most important points. The suture of the skulls are fibrous joints. Okay, so skull bones are joined together through these sutures that you have seen. This is the zigzag type of thing. They are joined together. So the fibrous joints with a fracture-like appearance found between the bones of the skull, and sutures are formed during embryonic development. They are sites for bone expansion, ensuring craniofacial growth during the embryonic, postnatal, and later growth periods. The cranial sutures ossify at different rates. The sutures of an adult skull are categorized as synarthrosis. So, again, I want to tell you that the ossification is different at a very different state, and sutures are formed already, but they are not ossified. The sutures of an adult skull are categorized as synarthrosis, and it is a type of a joint that a non-circumferential is totally immobile. So you need to know about it. These are the sutures. As you have seen, this is the coronal suture, this is the sagittal suture between these two parietal bones. This is the lambdite suture, where I've told you before, where the sagittal suture comes in contact with the lambdite suture. This point is referred to as the lambda, and where the sagittal suture joins the coronal suture, this point is known as the brachma. So these are the points that I have told you about. The lambda is a meeting point at the sagittal suture and lambdite suture. So obviously I have told you. But we need to especially know about the coronal suture, and this is why. I have told you before that coronal suture gives you an estimate of the central circus to the coronal suture, of the central circus. So a mean distance of the central circus to the coronal suture has been found to be 47.5 plus minus 7.6 mm. So if you know about the coronal suture, you have to think that about 47.5 mm on an average behind this coronal suture will lie the central circus. And this is important for you to estimate the motor cortex, the pre-central gyrus, which lies the precentral gyrus, and the postcentral gyrus in the sensory area. So these are the different rates of the closure of these sutures. The metopic suture you can see between these two frontal bones. It usually fuses between the age of 3 months and 9 months. And this is the coronal suture again between the frontal bone and the two parietal bones. They begin to ossify by the age of 24 years. Average suture closed between the age of 30 years and 40 years. The squamosal suture closed between 30 and 40 years of age. I have shown you the squamosal suture already on the lateral surface. The sagittal suture full abrasion will never occur, and the suture closes somewhere between 30 years and 40 years. The suture has been seen to close normally at the age of 26 and also remain open until someone is in their 50s. So it's like a very wide range. Lambdite suture full abrasion will never occur. Suture closes normally between the age of 30 and 40. Frontal sphenoid may close normally by the age of 3 months of age. So this is the condition that arises from premature closure of the suture. This is referred to as the craniosynostosis. So you can see over here, if there is an abnormal closure of the metopic suture, it leads to trigoncephaly. If there is any abnormal closure of the sagittal suture, it leads to schistocephaly. And in case of, you can see over here, if the lambdite suture is involved, it leads to synostotic posterior plagiocephaly. You need to distinguish it from deformational posterior plagiocephaly. which is when a baby develops a flat spot on one side of the head or the whole back of the head, and it happens when a baby sleeps in the same position most of the time, or because of problems with the neck muscle that result in a head turning preference. The deformation of plagiocephaly is also sometimes called as the flat head syndrome, and it is different from craniosynostosis since there is no fusion of the skull bone, it is positional in nature. So you have to think about it and you have to differentiate it. There is also, if just one half of the coronal suture is involved, that means the unicoronal nature, then it leads to the anterior plagiocephaly. And if both of the coronal sutures are closed, then it leads to brachycephaly. So this is the pterion, which I have shown you before and told you about. It's an H-shaped bony neurological landmark that is found at the junction of the frontal, sphenoidal, parietal, and squamosal part of the temporal bone. And it is located approximately 4 centimeters superior to the zygomatic arch and about 3.5 centimeter posterior to the frontal zygomatic suture. So pterion is located superior to the zygomatic arch and posterior to the frontal zygomatic suture. This area is known as the weakest part of the skull, like I have mentioned before, yet it overlies the course of the anterior, because it overlies the course of the anterior within the middle meningeal artery, making it vulnerable to EDS formation. In addition, it acts as an important landmark for locating the proximal speech area, the anterior pole of the insula, and the middle cerebral artery. The pterional site is important as it lies in close proximity to the middle meningeal artery and on the left side to the broca's motor speech area. So this is important for you to know about, so you have an idea of where you are going to operate and what you are going to expect and how to plan your surgery and how to assess the location. This location is important in surgical approaches to the anterior and middle fossa. In general, the pterion is considered to be located 2 plantar breaths above the zygomatic arch and a thumb width posterior to the frontal process of the zygomatic bone. So you have an idea how to look at pterion. The pterion forms an important landmark in pathological condition of many structures that are closely associated with it. It includes the optic nerve, the orbit, the sphenoidal vein, the middle cerebral artery, particularly its aneurysm and trauma to the middle meningeal artery. And apart from its importance as a landmark, a surgical landmark, it also is a guide for determining the age and gender and race in archaeological and forensic specimens. The pterional transcerebral corridor is used to treat aneurysm involving the anterior circulation and the basilar plex, the proximal segment of the superior cerebellar artery, the posterior cerebral arteries, IVMs, and cavernous hemangiomas. Actually, that pterional approach is basically the work of the pterional surgery. We might have, if you are in neurosurgery, you see that it's the workhorse of neurosurgeons, and it is very versatile. It is centered around this area. And there is a classification of pterions, and based upon the articulating bone, you can have the sphenoparietal type. You can see over here very nicely in picture A, the sphena and the parietal bone are coming directly in contact. This type of pterion is known as the sphenoterional variety, and the other is the frontotemporal variety. You can see in the B picture, the frontal and temporal bones are coming directly in contact. So this is the frontal temporal variety. In the stellate variety, all 4 bones are coming together, and there is a star-shaped configuration seen over here. That's why it is called as a stellate pterion. And this is the epitheric one, where you can see this is a little, small sutural bone between the parietal and the sphenoidal bone, and this is known as the epitheric pterion. So this is the classification of pterion. Similarly, asterion is an important anatomical landmark, and especially important when you are doing the retrosigmoidal approaches. So it is the anatomical landmark of the lateral spine formed by the, so you can see the occipital bone, the parietal bone, and it is the mastoid temporal bone. So over here, this is the asterion, and it basically gives you the idea of the transverse and sigmoidal sinus junction. You can see over here, and you can see there's a picture. You can see this is a posterolateral view of the left sigmoidal and the transverse sinus and the relation to the osseous landmarks, exposure of the sigmoid sinus anterior and inferior to the asterion. You can see the sigmoidal sinus, the asterion, that is after the exposure of the sigmoid sinus anterior and inferior to asterion. You can see the AS is the asterion anterior and inferior to it. When you remove the bone, you can see the sigmoidal sinus, and when you remove it, the overlying bone further, you can see over here, you can see the transverse sinus, and this is the junction, the proximal junction of the transverse and the sigmoidal sinus. So you can have a good idea of what I have been telling you about before. The name Asterion is from Greek and it means starry, and additionally also the proper name of the crater mentor. In anatomy, it is defined by the three suture junction at the lambdoid, occipitomastoid, and the parietomastoid sutures, where the occipital, temporal, and the parietal bones meet, and its reliability as a superficial landmark for the transverse and sigmoid sinus for surgical approaches to the posterior fossa can vary in different patients. So it's important for us to have this idea of variations that are present everywhere. The asterion can be located superficial, inferior, or superior to the transverse sigmoid junction, the sigmoidal sinus, or the transverse sinus. It is observed that the asterion is located superficial to the lateral half of the transverse sinus, directly superficial to the transverse sigmoid junction, sinus and sigmoid junction, inferior to the transverse sigmoid sinus and the sigmoid sinus junction in the lateral posterior fossa, and superior to the transverse sinus sigmoidal sinus junction. This is I just make it a little easy. So I just want to say that it is observed that the steroid is located superficial to the lateral half of the transverse sinus in 63% of the patients. It is directly superficial to the transverse sinus, sigmoidal sinus junction in 1%. It is inferior to the transverse sinus, sigmoidal sinus junction in the lateral posterior fossa in 22%. And is it superior to the transverse sinus, sigmoidal sinus junction in 14% of the patients, respectively. In general, from the asterion, the lateral transverse sinus is located directly underneath. The transverse sinus junction is 1 centimeter anteriorly, and the sigmoid sinus in the anterior-inferior direction, and the posterior fossa dura is in the posterior inferior direction. In the standard retrosigmoidal approach, the most important burr hole which should expose the junction of the posterior fossa dura and the margins of the adjacent transverse sinus and the sigmoid sinus is conventionally placed over the asterion or slightly below it. However, it is also argued that the following techniques are superior. In the Taranashi technique, placing the burr hole 6.5 millimeters inferior and 6.5 millimeter anterior to the asterion, and in the Rebars technique, 10 mm anterior to the asterion with the superior edge of the burr hole adjacent to the parietomastoid suture are the most suitable approaches for the placement of initial burr hole in the standard and extended retrosigmoidal approaches, respectively.